anybody pronounce his last name before anybody want to try?
Lauterbur?
Yep. Silent Darby.
Lauterbur. So he's an infectious disease doctor, so he's going to come talk to you guys about antibiotics and antibiotic resistance bugs. I'm going to run the rest of my
Thank you, Nikki.
Okay.
Well, good afternoon. Can you hear me okay? So infectious disease has changed an enormous amount in the last several years. And germs have become resistant. In the old days, you could treat anything with penicillin. Now, you can treat barely anything with penicillin. So we're going to talk about this in the next 2 hours, and you get a break. I get a break at 2. So we'll talk about basic antibiotic treatment in the first part. And I'm going to assume that you guys know how to treat Staph aureus, like with oxacillin and cefazolin, right? Okay. Because we're going to jump right into resistance. But what I think is much more important, and I hope to convey to you, is the nuances of infectious disease. And I'll explain to you what that is in a second. And then in the third thought, the third breath, we'll talk about common infectious diseases like UTIs and pneumonia and C. diff. And as time permits, and it will permit, because we'll make it so, talk a little bit about infection control. So with that as introduction, this talk is given by infectious disease people all over the place. And they have different titles, and I think just looking at the titles, you get some idea of what the issues are. Antibiotic stewardship is now the catchword for how to deal with resistance. I was at an infectious disease meeting last week in California. I'll probably refer to that 10 times in the next 2 hours. And I bet a third of the meeting was about antibiotic stewardship. And they were talking about multiple drug-resistant organisms, bad bugs and no drugs, the post-antibiotic era. I have a patient in the hospital now that can't be treated. Her germ is resistant to everything. It's an ID campaign. For those of you religious here, it's an ID calling. It's infectious disease in clinical practice. It's an update. It's a love affair with antibiotics, anti-antibiotics. Drugs of fear, drugs of sin, how to deal with antibiotic addiction. Musings of a grizzled ID clinician. Clinical ID philosophy, and just common sense. So Alexander Fleming discovered penicillin. Actually, I'm getting cold here. Oh, let me do it. Yeah. But Alexander Fleming discovered antibiotics a long time ago, and he got a Nobel Prize for it. And listen to what he said. This is why he got a Nobel Prize. The public will demand the drug, penicillin. Then will begin an era of abuses. The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out, which can be passed to another individual, and perhaps from there to others, until they reach someone who gets a septicemia or a pneumonia, which penicillin cannot save. In such a case, the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who finally succumbs to an infection with penicillin-resistant organisms. I hope this evil can be averted. He knew. I guess that's why that's how you earn a Nobel Prize. He knew what he had created. He knew what was going to happen, and it has happened. So we're going to talk about these germs here. So gram-positive cocci, and there it's MRSA, and then there's actually a little bit of vancomycin resistance, so it's called vancomycin intermediate Staph aureus and vancomycin resistant Staph aureus, VRSA, MRSA, and VRE. Gram-negative rods, everybody talks about ESBLs, extended spectrum beta-lactamases now. And worse still, there's this thing called CRE, carbapenem-resistant enterobacteriaceae. Fungi, mycobacteria, parasites, viruses, everything's resistant. Here's a cartoon for you. You are the next class of drug-resistant bacteria. As humans continue to abuse and overuse antibiotics, your ranks will swell. So go out there and mutate. And remember, that which does not kill us makes us stronger. You know where this statement came from? How about that? The gentleman from A&M, Nietzsche, the great German philosopher. That which doesn't kill you makes you stronger. That is exactly what's happening in antibiotics. Hey kid, want to be a superbug? Stick some of this and that double helix there, of course, is DNA into your genome. Even penicillin won't be able to harm you. So those are a few cartoons, but more seriously, the government has recognized multiple drug-resistant organisms, MDRO, and they have action plans. And you see there, World Health Organization and the CDC, President Obama, had an executive order a couple of years ago, and Nikki asked me if I had updated the slides. This slide is not updated, but I'm going to update it now for you. On January 1st of this year, the United States government, JCAHO, the organization that examines all hospitals, says you must have an antibiotic stewardship program. So antibiotic stewardship has now become mandatory by law for all hospitals. So that would be the third bullet here. So what we're going to talk about now is antibiotics, that are effective against multiple drug-resistant organisms. And as I mentioned to you before, we're going to talk about the nuanced confrontation of MDROs. And so importantly, when to not give antibiotics in the first place. I had a fight with somebody this morning who wanted to give antibiotics for somebody who wasn't infected. Right? When to discontinue antibiotics, that's a tough one, and when not to do cultures. And then, as I mentioned to you, we're going to talk about some common infections. These are things you can use tomorrow on rounds. And then the infection control issues I mentioned to you. So, if I get a call now on my, there it is, cell phone, and they say, we have a patient in the emergency room who's septic, whatever that happens to mean. Nikki, there's another topic for you. Sepsis is a very, very poorly defined, I'm not going to get into it, but let's just say that sepsis means you're really badly infected. I would respond, give every antibiotic you can think of. Vancomycin and Zosyn is what is commonly given. Vancomycin covers essentially all gram-positive copside, and Zosyn or piperacillin tazobactam covers most gram-negatives and most anaerobes. And I can tell you that not just in Oklahoma, but also in Alaska, and in California, and in New York, and in Michigan, all over Minnesota, all over the place, people get Vanco and Zosyn. And it's just like, it's a reflex. And it is appropriate. It is not inappropriate when somebody is doing poorly and you don't know what germ they have. If they're penicillin allergic, there was a big talk in California a couple of days ago about penicillin allergy being overstated. Like 10% of the patients that we see in the hospital are said to be penicillin allergic, but it's much smaller than that. It's probably only 1% of that. But that said, if you think that somebody's penicillin allergic, you have some substitutions you can use. Cephalosporins and carbapenems. But sometimes there's cross reactions. If a patient is seriously allergic to penicillin, they may also react adversely to the others. Then there's some other alternatives, aztreonam and quinolones. So there's ways to get around penicillin allergy. But vancomycin and Zosyn, everybody gets vancomycin and Zosyn ad nauseum. That said, there are some infections that don't respond to vancomycin and Zosyn, and I've listed them for you here. Tick-borne diseases, like Rocky Mountain spotted fever and Ehrlichia, in season. So this, even though it's warm outside today, the ticks are getting ready to, vacation. But in the spring, especially in Oklahoma, if a patient comes in septic, they would need doxycycline in addition. Because if not, they could die of spotted fever, for example. We're approaching influenza season. And influenza, you hear about all the time in the news, is not just a cold, it can be bad. And you would want to give that septic patient oseltamivir, Tamiflu. And there's two similar drugs, one's called zanamivir, and there's a new one out that you heard first here. It would be peramivir, IV for influenza. And that patient who's doing so poorly, or they come in, they're so sick, they're on a ventilator in the ICU, Paramivir. C. difficile is so common that you need to recognize it as a real source of sepsis. A nursing home patient, very common, received all sorts of antibiotics, and her roommate received all sorts of antibiotics, comes into the emergency room septic, they may well have C. difficile. And you want to give enteral, oral, of course, vancomycin, and/or metronidazole. Metronidazole can be given IV. Patients in the intensive care unit on vancomycin and Zosyn, and doxycycline and oseltamivir, and they start to do poorly, they may well have a PICC line, an IV-associated fungemia, candidemia, and you want to empirically treat for that with an azole or a kinocandin. There's this germ out there called the flesh eater. That's the nickname for invasive group A strep. One could argue that Staph aureus does the same. It kills you by toxin production, and you can inhibit toxin production with an agent such as clindamycin, not used so much as an antibiotic, but to inhibit toxin production. And there's an alternative to that, it's an oxaliplatinone. So that's empiric treatment. When you don't know what the patient has, but you know you want to give them every antibiotic you can think of, so when you come back the next morning, they're still there. But once you know what the germ is, you do culture-directed targeted therapy. So let's talk about how to treat MRSA. Vancomycin is the classic answer, and it works. But it's been used so much now that there's a thing called the MIC creep. And that's not, there's different definitions of a creep, like Harvey Weinstein's a creep. But this is vancomycin creep, and that means that it's becoming more and more resistant. The MIC is rising. So what do you do about that? Well, you use more vancomycin. But what happens when you use more vancomycin? You get more toxicity, nephrotoxicity in particular. So it's a drag. There are alternatives to vancomycin for MRSA, and here's one of them called daptomycin, otherwise known as Cubicin. And it is, it's not dissimilar from vancomycin. But that said, it has this very unusual quality of being inhibited by lung surfactant. So if a patient has MRSA pneumonia, daptomycin should not be used. And the dosing is not certain. It goes anywhere from 4 to 6 to 8, even 10 and 12 milligrams per kilogram per day. But when you start to use higher doses, you get myopathy, so you need to check CPKs. It is expensive. Vancomycin has been around for probably 50 years, and it's generic. And it probably works as well as daptomycin, but some people are using daptomycin preferentially over vancomycin. You ought not. There's another class of antibiotics effective against MRSA. They're called the lipoglycopeptides, the vancins, and there's 3 of them here: pelavancin, oritavancin, and dalbavancin. And the last 2, the second 2 there, are very interesting because they have an enormously long half-life, and you only have to give it once a week. And the way the representatives try to sell it, they say, listen, you've got a person who has staph in their system, like skin and soft tissue disease, and they could take vancomycin twice a day, or you could do this or do that. But give them my drug. One dose, and they're good forever. But I bring to your attention the cost of these things. They cost somewhere between $3,000 and $4,000 and $5,000 for one dose. And I'd ordered it once before, and I was called into the office by my pharmacist who said I was breaking the bank. But I bring your attention to these interesting drugs that you use once a week. Another class of antibiotics effective against MRSA are the oxaliplatinons, and there's 2 of them, linezolid, otherwise known as Zyvox, and Nikki had asked me in the hallway about this new one. It's called tedizolid, Silvextro. And they work against MRSA. They have the advantage of being oral as well as IV. And linezolid used to be extremely expensive. It was like, I think, $125 or $150 a pill. And you take 2 of them a day, so that's about $300 a day for 5 days, and you do the arithmetic. Now it's generic, and it costs $4 a pill. So you're all familiar with cephalosporins. I'll use the brand names, Keflex and Ancef and Rocephin. They're very common drugs, they're very effective, they're not toxic. And here is a 4th generation cephalosporin known as ceftaroline. The brand name is Teflaro, which is effective for MRSA. And you can use it for skin and soft tissue infections, and CAP stands for community-acquired pneumonia. There's another class of drugs out there which is effective against MRSA, and it's a tetracycline congener, like a higher generation tetracycline called tigecycline or Tigacil. And as I underlined here, it may have good in vitro susceptibility. In other words, it works well in the test tube, but in vivo, in a person, here are some of the issues. Low blood levels, so there could be breakthrough bloodstream infections, and low epithelial lining fluid levels, so you may have breakthrough pneumonia, and not too much elimination in the kidneys, so there may be breakthrough urinary tract infections. But that said, you'll hear me mention tigecycline several times now in the next couple of minutes. It covers everything, at least in this case MRSA. But it has a black box warning. I'm not exactly sure why the FDA did that, but a black box is like a hex. They discourage its use for the reasons noted here. We're still talking about MRSA now because that is the poster child of resistance. And there are some generic agents which work real well. And one of them is trimethoprim sulfamethoxazole, Baclofen. At this meeting in California last week, I met an old friend of mine who discovered Bactrim for MRSA. And I'm so proud of him, Norman Markowitz. All right. Then there's clindamycin, and that'll work for MRSA as long as it doesn't have this deep test that the laboratory will automatically tell you, so you don't have to understand what a deep test is. But it works for MRSA. And the tetracyclines work, at least some of them, and the one that's most potent happens to be minocycline. And a lot of people use doxycycline. So you've got all sorts of antibiotics which are effective against MRSA. So there's another gram-positive coccus which is multiply resistant, MDRO, and it's called vancomycin-resistant enterococci. And as I outlined for you here, or I highlighted for you here, it often plays a weaker non-pathogenic role. For example, in a decubitus ulcer in a nursing home patient, or in the urine, and treatment really isn't indicated. On the other hand, if it's in the blood, or the patient is otherwise septic, then you want to treat it. And I've listed for you here some of the treatments. Nitrofurantoin for a urinary tract infection, ampicillin if it's susceptible, the oxalolidinones, the tigecycline, daptomycin, maybe. So there's ways to treat it. So much for gram-positive cocci, MRSA and VRE. How about antibiotic-resistant gram-negative bacilli? And the 3 that are most important are extended-spectrum beta-lactamase producers, carbapenem-resistant Enterobacteriaceae, and the crab, carbapenem-resistant Acinetobacter baumannii. I've been practicing these all day. So ESBLs, everybody talks about ESBLs. Do you know what ESBLs are? Have you heard about it? People talk to you about it? Anyway, they're germs which have variable susceptibility to beta-lactams and carbapenems. And I went to a lot of talks last week in California about what to do about it. The resistance depends on the inoculum effect. Like if somebody has a lung full of ESBL, that's bad. If they just have a couple of germs in the urine, it's not so bad. It also depends on the antibiotic penetration. How much do you get in the urine? How much do you get in the lung? So what do you do when you're confronted with a beta-lactam, with an ESBL? Well, you can use a beta-lactam, beta-lactamase inhibitor. And I've listed them for you here. Just use the brand names because it's easier. Zosyn and Zerbaxa and Abicaz. But by definition, if these germs are producing beta-lactamase, they may destroy the beta-lactam and beta-lactamase inhibitor that you're trying to use. And it's a real bind. That said, industry has come out with 2 new drugs, this ceftolozane, tazobactam, and ceftazidime, avibactam. Recently, like in the last couple of years now. And the question posed in California was, when I say California, you understand this is the national annual meeting of infectious disease. They said, are these the answers? Are Baxa and Abicaz, is that what we're supposed to do now for ESBLs? And the answer is not known. They haven't been around enough, they haven't been studied enough. But there's so much hand-wringing and hair-pulling, nobody knows what to do, so the FDA allowed these drugs to be licensed very quickly without really knowing how effective they are. But they may work for resistant Pseudomonas aeruginosa, they may work for complicated urinary tract infections, they may work for complicated intra-abdominal infections, and that's what industry is trying to do in front of this epidemic. The real answer for an ESBL is usually a carbapenem, and they're listed here. Meropenem, merum, doripenem is Doribax, and imipenem, silostatin is known as Primaxin, and ertapenem is known as Invax. So those are the drugs of last resort against ESBLs. Tigecycline appears again, but I told you before about the in vitro and in vivo concerns, and it never works for Pseudomonas and Proteus. And then the carbapenem-resistant Enterobacteriaceae. When you hear on the news that there's germs out there that are resistant to everything, this is what they're talking about. A nurse called me not too long ago and she said, I've got this germ and there's straight R's on the resistance panel. She said it's completely resistant to everything. So what do? Well, you try tigecycline perhaps, or this antibiotic which has been available, which was invented 50 years ago, they call it polymyxins. Nobody uses them anymore because they're too toxic for neurotoxicity and nephrotoxicity. But when the germ is resistant to everything, there's a resurgence of use of polymyxin. There was a big talk on polymyxin and how that might address antibiotic-resistant gram-negative rods. And then the carbapenem-resistant Acinetobacter baumannii is very difficult to treat. You can use this thing called Unicin, ampicillin sulbactam. Interestingly, it's a sulbactam more than the ampicillin, which seems to be effective. Tigecycline, there it is again. Minocycline, kind of tetracycline, since people don't use tetracyclines much anymore, may be effective against this. And then there you see again the polymyxin. So depending on how sophisticated you are in microbiology and antibiotics, you can say, listen, if you're talking about beta-lactamase production by ESBL, why don't we just use some antibiotic that's not a beta-lactam? It won't be destroyed by a beta-lactamase. That's a good question. For example, quinolones. TXS stands for trimethoprim sulfamethoxazole. Aminoglycosides, shouldn't they work? They're not beta-lactams. The answer is unfortunately no. There's this cross-resistance that becomes complicated when you've got plasmids and they start to share with each other. So that these other non-beta-lactam antibiotics unfortunately don't usually work. So as far as quinolones go, I sort of threw this slide in because I think I need to mention to you that they're effective broad-spectrum antibiotics. They come orally, of course. They don't have too many side effects. And for this reason, they're prone to abuse. And the FDA said, stop using quinolones. With that said, everybody uses Cipro, or Levaquin, or Avelox. And the nuances of differences I've shown here. That Cipro is relatively less effective than the others against pneumococcus, which is a major cause of pneumonia. Levaquin, on the other hand, works better for the pneumococcus. And Avelox is a nice drug, but there's not that much in the urine, so it doesn't work for urinary tract infections. Trimethoprim sulfa, Bactrim, Septra, works for a lot of gram-negative rods, even this unusual one called, who wants to say that one for me? Stenotrophomonas multifili. Aminoglycosides. In my my training a long time ago, I used to use a lot of aminoglycosides. Because they're effective, but unfortunately they were toxic. Now, with all these new antibiotics, we don't use much aminoglycoside. A question that's often asked, when you have these resistant gram-negative rods, this dreadful epidemic, should we be using 2 agents? And it's sort of a myth. It's not necessary for efficacy and synergy, but empirically, for this patient that comes into the emergency room septic and you don't know what she has or he has, you give as many antibiotics as you can think of. Theoretically, if you give 2 antibiotics, you'll prevent resistance, and this is well known in diseases such as TB. You have to use at least 2 drugs, and HIV, you have to use at least, or you use 3 drugs. But whether this applies to gram-negative rods or not is unlikely. So we talked about gram-positive, COP-side gram-negative rods. Another big class is anaerobes. The basic treatment for that is metronidazole or Flagyl. Clindamycin works, but there's resistance. And the laboratory doesn't test for it, so you won't know. There's this class of drugs that we've already talked about, the beta-lactams, beta-lactamase inhibitor combinations. We're talking about Zosyn and Unison. And then there's this other class called carbapenems. These agents that are listed here are extremely potent against anaerobes, as good as metronidazole, Flagyl. So you don't need to add metronidazole, let's say the Zosyn. But I see that all the time. It's called, what's what antibiotic stewardship says it's redundant. So you see people writing Zosyn plus Flagyl. Flagyl is unnecessary, redundant. The quinolones, at least the moxifloxacin, works for anaerobes, and there it is again, tigecycline. Fungi, I'll just briefly mention to you, but they are to be reckoned with. And they can be treated with 3 classes of antibiotics, the azoles, the echinocandins, and amphotericin. The azoles are listed for you there. They've come out with some new ones recently. But even there's resistance. And the echinocandins are very popular now, mycofungin for possible acquired candidemia. And amphotericin used to be used commonly because that was the only thing we had. But it was toxic. So we don't use much amphotericin anymore. They've addressed toxicity by putting the antibiotic in a liposome. It makes it somewhat less toxic. So there. In 27 minutes, I told you how to treat, not the common germs, well, I take that back. Not the sensitive germs, those I hope you know how to do already. But the resistant germs, that's how you do it. But it's more complicated than that. I mean, as students, PA students and everything, you're smart, you'll be able to memorize this. But what's less obvious is this epidemic of infectious disease overdiagnosis and overtreatment. I'm going to call it MDRO, hypochondriasis. So when you get a call, not me, maybe you, but somebody else, and they say, we just admitted this patient from the nursing home, 100-year-old with the cubiti all over, because they can't move. They've got MRSA, VRE, ESBL, et cetera, and your answer is OMG. So these germs shouldn't be there. I mean, this is what they call dysbiosis. We're going to get back to dysbiosis a little bit later. And by definition, they're resistant. But they're not necessarily playing a pathogenic role, and they could be what I'm going to call benign commensal colonization. So if we go to a nursing home this afternoon and start to culture people, you'll see all these germs. But the patients are sitting there eating lunch and watching TV, and they're okay. So you don't have to treat these germs just because they're there. You use your clinical sense. If the patient's sick, you treat them. If they're not sick, you don't. That's pretty obvious, right? You're probably wondering why I'm telling you that. The reason is everybody does it.
Wouldn't that potentially make you liable if the patient did catch whatever infection and you hadn't been treating it for however long?
Are you a PA student or a lawyer student? You're absolutely right, and that's why, and I'm going to get to that, that's in the second hour, that a lot of people, perhaps you, and a lot of other physicians, smart physicians say, listen, there's an ESBL in the urine, and I better treat it, because otherwise if that patient gets septic tomorrow, I've done the patient wrong, and the lawyer's going to get on my case. The answer is no. I mean, and I would say this, all right, as a retort. If you treat that patient unnecessarily, you engender more resistance, and they get C. difficile, then I'm going to sue you. And that's the truth. But a lot of people think like you do. I'm glad you asked that question. And it was asked to me this morning by, no, the answer is you don't just treat the germs, you treat the patient. Treat the patient, not the culture reports, common sense. All right, so what are the obstacles to common sense? It looks like you've been reading ahead of time here. It's compulsion to obtain cultures. And then once you see it, like the gentleman says, once you see it, their ESBL, you just feel you got to give antibiotics. And you can have an app. Bugs and drugs. If you don't know how to treat an ESBL, you push the button and tell you how to do it. Unfamiliarity with and/or resistance to the concepts of asymptomatic bacteria, which you're going to get. It's a very important issue. We'll get back to that. Having germs in the urine which are not hurting anybody. I mean, most of the people, well, you're a bunch of young people. And you're women. Have germs, asymptomatic bacteria. Nobody's sick here, But if we did the urine culture and everybody, when they walk out the door, somebody's going to have an E. coli in the urine. I'm sure of it. And it doesn't need to be treated. We'll get back to that. And colonization, and contamination, and commensalism. I had a consult this morning on a patient who had gram-positive cocci in their blood. They were being treated, as they say in Oklahoma, out the wazoo. And I had to convince everybody that this was a staph epi contaminant. Everybody has germs on their skin, and they got into their blood culture bottle. Fear that colonization will evolve into clinical infection. Before you get staph in your blood, you might have it on your skin. Or E. coli in your blood, you might have it in your urine. And it happens. But in that case, everybody in this room should be on antibiotics now forever. So you can think this is the absurd. And then you've been reading ahead. There it is, number 4, fear of legal retribution. If you don't start treating everything, the lawyer's going to get on your case. I've been there before. Then insufficient respect for MDRO. This is my answer to you, sir. The insufficient respect for multiply drug-resistant organisms and C. diff and adverse drug reactions. If you treat this person with an ESBL and they get a rash, you've not done them any good, and you've caused a side effect. So what do you do to help avoid over-treatment and avoid over-diagnosis? So when not to culture, avoid cultures unless the patient is clinically infected. For example, don't culture the urine unless there are UTI symptoms. This is so important, and I don't know how to express it, how to get you to do it. But to give you an example, I was, when you come through the emergency room, if anybody, we could do a study now. We'll send, a couple of people here, go to the emergency room down the street. And you say, I don't feel well. You'll probably get a urinalysis and a urine culture, even though you have a cold or hay fever, or you're just, doesn't make you believe. And then the urine comes back, positive. There's white cells in the urine, and there's E. coli in the urine, and you're on an antibiotic. This is how it happens. But if they didn't do the urine culture in the first place, it wouldn't have happened. So I've been at meetings with the emergency room in particular, because that's where it starts, and saying, don't culture the urine, unless there are really symptoms. It's extremely important. Don't culture wounds. It's not that we go to the nursing home and see somebody who has a decubitus ulcer, and some well-meaning nurse or PA or physician or somebody cultures it and is growing everything. And that engenders, vancomycin and then C. diff, and you're in this spiral again. Don't culture blood unless there are signs of sepsis. I also do infection control. That's part of being an infectious disease person. And there's this epidemic of contaminated blood cultures. People were getting staph epi in their blood, and they were getting PICC lines in and vancomycin. And they asked me, how to address this epidemic of contaminated blood cultures. What was the answer? Stop culturing the blood, unless they really need it. But they were culturing the blood for no reason. All right, so antibiotic stewardship 1. What is it? When to withhold antibiotics. So now, there are a lot of times when antibiotics should not be given. And I'll read through it for you. Respiratory tract infections. If one of you guys gets, or I get, a cough this afternoon, or a sore throat, or a sinusitis or bronchitis, it's very likely, most likely, 90% plus a virus, and it doesn't need antibiotics. And for that matter, it might well be an allergy, hay fever. It does not need antibiotics, but that is one of the major reasons why people get antibiotics, because they sniffle. Bad idea. Non-infectious cardiopulmonary disorders are often misdiagnosed as pneumonia. For example, CHF. CHF is very common. Antibiotics. I don't, thank you. CHF is very common. Somebody comes in the emergency room, an old person, short of breath, coughing, and they get antibiotics, but they really need Lasix. And then earaches. So I don't know how many of you are mothers or fathers or grandparents, but so kids, our kids get earaches, and in selected cases, there's a lot of literature that suggests you don't need antibiotics. And skin and soft tissue infections. The one that I bring to your attention in particular is bilateral lower extremity inflammation from what they call stasis dermatitis, or venous insufficiency. So both legs look, they're inflamed, and then they could almost be as red as this Coke can. But it's not an infection, and they don't need antibiotics. And then we've already talked about, and we will continue to talk about, asymptomatic bacteria and pyuria, even in patients with Foley's who don't need antibiotics. And then we've already mentioned several times about colonization and contamination, which takes some clinical acumen to know if a staph epi in the blood has really infected somebody or not. But the answer is you have to be aware of colonization and contamination, which don't need antibiotics. And this gets a little bit more nuanced still, but low-grade fever. Pleasure. All right, too late. A lot of patients will come to see you and they'll say, I have a fever, I have a low-grade fever. And I'll say, your temperature is 98. They say, yeah, but my normal temperature is really 97. But now that I'm 98 too, I'm highly febrile. You say, give me a break, you don't really have a fever. But a lot of patients, maybe, I hope I didn't insult anybody here, but feel that way. And likewise with leukocytosis, you see somebody, a normal white count, let's say it's 10,000. So they come in, it's 11.5, they end up on vancomycin. There are other reasons for a 99 temperature and white count of 10,000. Very briefly, there's a great paper. So the temperature of 98.6, that's a normal temperature in Fahrenheit, was discovered over 100 years ago by this guy named Wunderlich. And he had a machine which was probably twice as big as this, and he measured over, I think it was over 1 million temperatures, just on normal people, and he came up with 98.6. So that's, all the thermometers, at least in my day, were etched, 98.6, when we had the mercury thermometers. But somebody, I forget his name, did a study several years ago. He only had like 100 patients. I think he had like 100 PAs and medical students. And he said the real normal temperature is up to 99.9. So there, 98.6 is, so if somebody has 99.9, they don't have a fever. Enough said. So it's getting more complicated now. When do you stop antibiotics when somebody is on them in the first place? All right? And here's some answers for you. First of all, I need to tell you that it's not that well studied. Nobody knows exactly how long to give antibiotics. But that said, here's some answers. I'll give you another. There's an enormous movement now in infectious disease to give shorter courses, because longer courses are not necessary for efficacy, and they engender more resistance, more C. diff, more rashes. So anyway, that said, streptococcal pharyngitis has been 10 days. Skin and soft tissue infections, 5 days. Community-acquired pneumonia, 5 days. ventilator-associated pneumonia, or healthcare-associated pneumonia, 8 days. Intra-abdominal infections, 4 to 7 days. C. diff, 10 to 14 days. Urinary tract infections, depends on the study, depends if it's just cystitis or pyelonephritis or catheter-associated, so it's variable. Surgical antibiotic prophylaxis, 1 dose before surgery is it. And these numbers that I show you here are shorter, much shorter than you might be accustomed to, or at least people older than you that have been in medicine longer, they give much longer courses. It's wrong, and the Infectious Disease Society of America is pushing this. Now, there are some infections you have to treat for a long time. They're listed here: endocarditis, weeks, 2, 4, 6, 8 weeks, and osteomyelitis, several weeks. But that said, there's an enormous push to treat for a shorter period of time. So now it gets even more nuanced, and now more on thin ice, okay? Because there's less and less data as this thing progresses. But patient-specific, personalized antibiotic duration. I mean, that's how things are done. People are different. Each one of us is different. Each one of our infections is different. Each one of the germs is different. So I say here, infections are variable in their intensity, their evolution, in their response to antibiotics. And individuals, react differently to them. So therefore, should the therapeutic endpoint likewise be variable, personalized to a patient's physiologic response? Let me see the next slide here. Yeah. So what you do is, say in your clinic, or wherever you end up in the clinic, or the hospital, or wherever you end up, how do you know when the antibiotics can be stopped reasonably? Well, you ask the patient, how are you feeling? Great, I'm much better, thanks very much. You take their vital signs, the temperature is normal, their pulse is normal, their white count is normalized. And then there's these inflammatory biomarkers, sed rate, and CRP, and PCT, procalcitonin. And you say, well, everything's normal, we can stop the antibiotics. Procalcitonin has become a big deal recently. It's the sed rate and this thing called the CRP, C-reactive protein, are old. But somebody invented a new inflammatory marker called the procalcitonin. And I'll just read this for you here. It's a sensitive and specific marker for bacterial infections. And it rises very quickly when somebody has a bacterial infection. It decreases rapidly when it's gone. It's not affected by anti-inflammatory agents or immunosuppressants. And the way it is used in 2 ways. The second way is to tell if somebody has a bacterial infection or a viral infection or no infection. Besides a bacterial infection, if it's not, that they don't have a bacterial infection, they don't need antibiotics. But the first way that it's used is for duration. So if somebody comes in and they have pneumonia and their procalcitonin is high, I'll make up a number, 50. And normal should be, let's say, less than 0.5. So they come in and their procalcitonin is 50, and you're giving them antibiotics and they're getting better. How long do you give it? Well, you do a couple of procalcitonins every day or every other day. And when the procalcitonin decreases by 80%, you can stop the antibiotics. So that's the newest, hottest inflammatory marker. And the people in California, the world's experts, they like it. Customized regimens will likely lead to a greater appreciation of the efficacy and safety of shorter durations of therapy and may be an important means of limiting adverse outcomes. Less is more. Problem is, man has this inborn craving for medicine. The desire to take medicine is one feature which distinguishes man, the animal, from his fellow creatures. I've actually seen a patient or two who are addicted to antibiotics. And everybody talks about the opiate, crisis, which is a big deal. But every now and then, there's really weird people say, I want more antibiotics. So here's a funny one for you. I can barely read it. Dear Miss Know-it-all, what should I give a friend who truly has everything? The answer is a broad spectrum antibiotic. Here's one you can put in your waiting room. Don't forget to take a handful of our complementary antibiotics on your way out. All right, so why do we do this? That is a question that I asked myself and and try to answer it. And this addresses that gentleman up in the right center field there, right field. And there's 9 reasons. So we'll go through each one of them and then we'll take a break. So the perceived standards of care. I mean, you're just beginning your training now. But for me, I remember, going way back, the professor, who knows, maybe he won a Nobel Prize. He says, you treat pneumonia for 2 weeks and urinary tract infections for who knows. And you believe him. I mean, that's what training and experience is. And then prescribing etiquette and professional culture. If the professor says to do it, you do it. He must know what he's doing. That's why he's a professor. There's a lot of cross coverage now, more than ever. Handoffs, right? Because nobody's supposed to work more than, 8 hours or 12 hours? Or, so you can't work now for long periods of time, understandably. So you pick up patients from your colleagues. And they have a patient who's still on antibiotics. You say, well, they must know what they're doing. And I don't know the patient that well. I'm just going to keep doing what they're doing. Concerns over discontinuing other prescribers' orders is a big one. Another thing is like what I'll call therapeutic inertia. We'll just keep giving the antibiotics until they send them home. Who knows when they're going to go home, but once they go home, we'll stop the antibiotics. I would say the most common standard of care is we'll give antibiotics for 5 days, or 7 days, or 10 days, or 14 days. Where did that come from? It's round numbers. I had a friend when I grew up, old Martin. He had polydactyly. He had 6 fingers. He had 12 fingers. He had 12 toes. So does that mean he gets antibiotics for 6 days or 12 days? I mean, you understand that these decisions may be more arbitrary than biologic. And giving antibiotics, to a polydactyly for 6 days or 12 days doesn't make any sense. Fear of relapse. I mean, this is they're all big, but this is another big one. You want to keep on giving antibiotics just to be sure. You say, listen, you're better now, but man, if this pneumonia or this urinary tract infection comes back, that's bad. So I'm going to keep on giving you antibiotics, just to be sure. But there's no evidence that longer courses achieve better outcomes, and in fact, recent data suggests that shorter than traditional regimens are effective for common infections, and that relapses are rare. And this is a fear we all have. Better give just a couple of days so you don't relapse. So there's a correlate to this. So somebody's in the hospital, and they're on IV antibiotic, vancomycin, okay, and they're doing well, and everything's normal. So according to what I told you a second ago, you can stop antibiotics. But they said, let's do an IV to PO switch. Let's give you a chaser. Let's give you another week of quinolone just to make sure you don't relapse. This IV to PO switch is a big part of antibiotic stewardship, but I maintain that once a person's better, they don't need any more antibiotics. IV, better, stop. Here's another big one, diagnostic uncertainty. I mean, no matter how good you are, if you're Sir William Osler or if you're as good a clinician as you are, a lot of the time you have no idea what the patient has. I mean, it's a little bit embarrassing to say that or to admit defeat, but if a patient comes in, you don't feel well and you just don't know what they have. So this drives providers to overtreat rather than undertreat. And I'm going to read this in red here. Antibiotics may be continued in the absence of improvement or even despite the presence of a documented non-infectious etiology. I guess what I'm trying to tell you is that if you don't know what somebody has, they get antibiotics. Let's say it's not unreasonable to do that. But you ought to rethink that after a day or two, and there's an official designation for that. It's called an antibiotic timeout. So after you don't know what they have, and they've been in the hospital for 2 or 3 days, and you say, time out, let's reassess. Hey, they really have congestive heart failure. They got better on the Lasix, not the vancomycin. Stop the antibiotics. There's this misconception that a shortened course of antibiotics promotes resistance. But in fact, prolonged courses are associated with increased resistance. Pharmacists are also responsible for this. I mean, they don't write the orders, they just fill them, of course. But if you go to a pharmacy, let's say you go down the street to CVS today with a with a prescription that says, take these antibiotics for 10 days. The pharmacist will tell you, do what the doctor says. Make sure you keep on taking them, even if you feel better. Take, empty the bottle. That's wrong. There's no reason to do that, but that is commonly done. All right, back to this gentleman. You're getting picked on here a lot. Fear of legal retribution for insufficient antibiotic treatment. But overtreatment can also lead to litigation. I know of a case or two of somebody got C. difficile on antibiotics that they didn't need. I know a young woman who had asymptomatic bacteriuria, didn't need antibiotics. She received trimethoprim sulfa, had a what do you call it? Her skin, she looked like she was burned. She was actually in the burn unit. Her skin peeled off. What's it called?
Stevens-Johnson.
Yeah, Stevens-Johnson. Thank you. She didn't sue, but she should have. She said, I didn't even need the antibiotic, and I look like a burn patient. So, terrible. All right, your infection may be antibiotic resistant, but let's see how it responds to intensive litigation. All right, so those are my 5, but here Dr. Metley wrote another 3. Lack of accountability for antibiotic use, particularly at the individual prescriber level. This is changing a little bit, but if you, when you become you start rounding, and let's say you give antibiotics to everybody, you're not held accountable for that. But that's changing now because for credentialing and re-credentialing, they'll see if you're an over-prescriber. Time management and patient satisfaction. Favor prescribing over non-prescribing. You're busy. You're working at a clinic, you've got a good job, and you see 30 patients a day. My God, how can you see that many patients? If somebody coughs, sneezes, coughs, they get antibiotics. Next patient. Universal presence of antibiotic prescribing pressure. This is actually a really big one. There are, what do you call them, initiatives now. Sepsis protocol. Sepsis is a big deal. It's called the Surviving Sepsis Campaign, right? And they say, don't miss sepsis. If you think somebody's not doing well, you got to do blood cultures and do a lactic acid and give them antibiotics. And the emergency room is very liberal in doing that. Pneumonia, same thing. Literature says, the sooner you get antibiotics for pneumonia, the better you do. So there's all this pressure to give antibiotics before you recognize that a patient really has CHF and not pneumonia, or a patient is dehydrated and not otherwise septic. So this is an unwanted consequence of these initiatives. This is a nasty one, but I'll tell it to you anyway. The culture and antibiotic gaming, otherwise known as administrative factors. Where did this come from? Definition. So what you'll see, what I've seen at nursing homes, it's usually long-term care facilities, like nursing homes and LTACs. They make their money by keeping patients in there for a designated period of time, like maybe 25 days. If it's less, they get less money, and if it's more, they lose money. So the system is set up to justify stay, doing cultures, and giving antibiotics. It's fraud. To justify stay, to justify reimbursement and upcoding, and even to justify an infectious disease consultation. So you don't want to get involved with that. So what do you do? What's the bottom line? And then we'll take a break here. For the coughing patient seeking a Z-Pak, Dr. Abigail Zuger wrote this. She said, I have some great, see, this is what you tell your patient. She said, I have some great news for you, some wonderful news. This time you don't need antibiotics. All right, time for a break.